Good morning, everyone, and welcome to our Lunch and Learn on Disability, Poverty, and Medical Assistance in Dying, First Voice Advocacy Perspectives. So deeply grateful to Dr. Tammy Bernasky for joining us and sharing some of her wisdom, knowledge, and research experience with us. Let us begin first by grounding ourselves in gratitude. So as wherever you are joining us from across Turtle Island, which is what the indigenous people of quote unquote North America call this continent, I invite you to think, where do you feel most grounded? Just take a moment for gratitude for where you are. For gratitude, maybe you feel most connected to the land when you are in your garden, or maybe it's the beach, or maybe it's a hiking trail or a park, but wherever it is, just take a few moments to connect with that sense of gratitude and groundedness. And I invite you to join with me in the chat and acknowledge the Indigenous name of where you are located. So for example, if you're located in Halifax, you would say instead, there's Puktuk. I would like to begin by acknowledging that I am speaking from Unama'ki, which is located on the ancestral and unceded territory of the Mi'kmaq, whose inherent rights were recognized in the peace and friendship treaties that were signed with the Mi'kmaq, Maliseet, and Passamaquoddy peoples from 1725 to 1779. This series of treaties did not surrender Indigenous land, resources, or sovereignty to the British Empire, but instead established rules for an ongoing relationship between nations. The treaties were later reaffirmed by Canada in Section 35 of the Constitution Act in 1982, and they remain active to this day. Let us take this time to pause in reflection and gratitude for the land where we live and work. And we take this moment to recognize that the Truth and Reconciliation Commission of Canada has specific calls to action that impact us as social workers. And so we take this moment to think about what truth and reconciliation really mean. The Nova Scotia College of Social Workers commits to translating our acknowledgement into action. By seeking to implement the recommendations of the Truth and Reconciliation Commission's calls to action, we commit to doing what we can to becoming better treaty partners. We commit to learning and to unlearning. And we also recognize that the new CASW Code of Ethics requires us to shift from the illusion of neutrality to actively becoming anti-racist and fighting against racism and all intersectional prejudice that is part of colonization. We are, as social workers, in the process of reconfiguring our role in this world to become safer by recognizing the interconnectedness of all the different systems of violence that exist on this planet. Intersectionality is a term that was coined by Kimberly Crenshaw, the African-American feminist, who talked about the ways in which oppressive systems sustain each other and that they can have a amplifying effect. And it is a way in which we can see where power comes and collides and intersects and acknowledges that each of us have our own unique experiences of discrimination and privilege. We also recognize that becoming anti-racist and decolonizing ourselves is a journey from denial that it exists and fear to unlearning and learning to eventually growing towards a world that we can't even imagine because of how pervasive all of the systems of interlocking oppression are. But we want to recognize that fear is a large part of why people sometimes avoid recognizing it. And when we are doing our advocacy, that is something to think about as well. And when we're thinking about decolonizing ourselves, if we are avoiding the ways in which we are complicit, what are we afraid of? And how does that impact our ability to provide safer social work practice? Decolonizing ourselves in our practice means recognizing the ways in which we're each impacted by the colonial system in which we all participate and from which those of us of settler descent continue to benefit. Each of us, depending upon our social location intersectional positionality, are uniquely impacted or oppressed. For example, those of us from African descent were dispossessed and uprooted from their land and brought to Turtle Island against their will as part of the white supremacy and slave trade that fueled the settlement of this continent. So let's take this moment to reflect upon the unique impact of colonization upon us. We're all treaty people. So how does this impact what we do and how we do it, and how will it guide our work together today? So we want to honor our Mi'kmaq colleagues and the values of this land by starting in a good way, which means to pause in gratitude for all who have and continue to heroically care and advocate for this beautiful land. May we join them in this sacred work, grounding ourselves in the wisdom of the land-based Mi'kmaq teachings that we must all begin to learn. Let's work to decolonize ourselves, our practice, and this community that we share by working for justice for all living beings as an expression of our gratitude. So let's take a deep breath and recenter ourselves away from the violent ways colonization fills us. And another deep breath to work on letting go of the unconscious bias that is everywhere, inside and out. And may our session today lead us to be in right relationship with this land and with one another. And with that, so deeply grateful to Dr. Tammy Bernasky for joining us and sharing some of her work, research, passion. We are very, very grateful.
Thank you so much. I'm just going to share my screen here. Okay. Can you just give me a thumbs up if that's okay? Looks good? Okay.
Perfect.
Thank you so much for the opportunity to speak today about disability, poverty, and medical assistance in dying. This is a subject that is still unfolding for me and one that I'm quite passionate about. So any opportunity to speak about this is a welcomed one. I will start by saying that I'm not a complete expert in how this is unfolding, just because there's so much information that we don't know. But my intention today is to share with you some of the things that I do know about the intersections of poverty, disability, and the utilization and interaction with medical assistance in dying in Canada. So what I'm going to do today is just try to help with the understanding of the links between poverty, disability, and MAiD. We'll look at the bi-directional link between poverty and disability because that is established in Canada and also globally, but we'll focus on Canada today. We'll look at the current state of social supports for people with disabilities in Canada, and towards the end, I'll talk about some of the newer developments related to disability supports. And then I'm going to speak a little bit about medical assistance in dying in terms of qualifying for MAiD and also the utilization of the process. And so hopefully by the end of this session today, we'll have a better understanding of how all of these things are connected. So the newest statistics around disability in Nova Scotia are that 38% of Nova Scotians have a disability. And I'll be clear here that disability is defined in the Convention on the Rights of Persons with Disability. It's not actually defined, but it's treated as an evolving concept. So it's really about the ways in which our experiences interact with society to create barriers. So it could be things like physical disability, but it's also things like mental health issues, neurodivergent, sensory issues, learning disabilities, intellectual disabilities, and so on. Lots of different kinds of experiences are encapsulated in this statistic. What we also know is that income supports for people with disabilities in Canada are not adequate for maintaining quality of life. And we saw this most prevalently when we looked, when we experienced COVID-19. So we saw that in times of emergency, when people couldn't work because of health reasons, the government decided that folks who couldn't work because of that were eligible for the Canadian Emergency Response, COVID Emergency Response benefit. And that benefit was $2,000 per month per individual. Now, income supports for people with disabilities and people on social assistance are not that high across the country. So really what started happening was where advocates were saying, if we decide that in an emergency, people need around $2,000 a month to survive, then why is it that our social assistance and social support networks don't offer the same level of um, support? So in Nova Scotia, we'll focus on Nova Scotia here, the standard household rate for a single person renting or owning a home is around $974 a month. There are some other smaller benefits that might be attached to that, but recognizing that if you look at the disability support program policies, on the screen, I'm showing the household composition as well as the standard household rate. And so if you're a single person with no spouse and no dependents, the rent to own is $974 with $275 for essentials. If you're living with a spouse, then it's a bit more. It's $1,376, and if you have a spouse and dependents, it could be $1,428. So this is just in recognition of the amount of supports in Canada. It varies, or in Nova Scotia, sorry, it varies across the country, but we'll focus a little bit on Nova Scotia today. So I'll provide some statistics here that Canadians with disabilities are twice as likely to live in poverty than those without. I have references at the end that correspond with these statements, I guess. The link between poverty and disability is strong due to things like structural barriers to accessing very important social determinants of health, including education and employment. So education, even though the number of students with disabilities in post-secondary education is rising, there's still many barriers for students with disabilities in terms of completing their education and getting access to quality education as well. In terms of employment, there's a lot of misconceptions about people with disabilities, that we're not productive, that we might be a liability, all kinds of false perceptions that aren't true. But there is work being done to create what we call more disability confident employers. That is, employers who are confident in recognizing the attributes that people with disabilities bring to workplaces and the diversity they bring as well. But there's still lots of barriers in those two areas, which will inevitably lead to higher rates of poverty for people with disabilities in Canada. I want to talk a little bit about attitudes. This this could fit anywhere in the presentation, but I think I decided to put it here because there's a lot of negative attitudes that still persist around disability in this country and globally. I taught a course on media and disability. I also taught a course around stigma that looked at media perceptions of disability and so on. And some of those negative attitudes include things like it's undesirable or tragic to have a disability, that people with disabilities are unproductive and we don't contribute to society. And I'll just state here that I'm saying we because I identify as a person with a disability. There's also negative attitudes that people with disabilities are a burden, either to their families or to society, or that it's really pitiful to have a disability, or that we're in need of saving. There's also that heroic perception that exists that's also quite harmful, and the idea being that uh, if you're achieving in society and you have a disability, then you're exceptional in some way, when really people with disabilities just achieve things like everybody else. These misconceptions are highly reflected in media and perpetuated. So that is to say that these perceptions exist. A lot of times when we see these things in movies or TV shows, we don't really question it, or people don't really question it because it's just an accepted truth. So really, when we see these perceptions in media, we want to recognize that they also play out in other ways. So this could be particularly in terms of playing out in society. And I'm noting this here because I'll talk a little bit more about how these attitudes are important when we think about medical assistance in dying. But I'll come back to this point. Okay. Just a little bit of history. I won't go into too much of the detail here because we don't have a lot of time, and I want to get to some of the criteria. But in terms of the history, Sue Rodriguez was the first person to make a challenge to the criminal code, which under the criminal code, it's a crime to counsel or assist someone to commit suicide. So in 1993, Sue Rodriguez challenged that section of the criminal code to say that it was violating her rights under the Canadian Charter of Rights and Freedoms. She lost her case. And interestingly, she still died with a physician-assisted death, but nobody was ever charged in that case because nobody would come forward as a witness. And then in 2015, we saw the Carter versus Canada case, which the court found that the criminal code provisions that make it a crime to help a person end their life violate the Canadian Charter of Rights and Freedoms. And so in 2016, the criminal code was actually amended to allow for medical assistance in dying. Particularly, they added exemptions for medical professionals who were assisting people in the process of applying for MAiD and then implementing that process. I'll come back to this in a minute, but in 2021, the legislation was further expanded, and that's a part that I'm going to focus on. It was expanded to remove the natural or foreseeable death requirement, but I'll get to that in just a moment. So there's a lot of safeguards in place and eligibility criteria that must be met, and this is written right into the criminal code. The person, if they're applying for MAiD, they have to be eligible for health services covered by the government. They have to be at least 18 years of age. You have to have a grievous and irremediable medical condition, and I'm going to explain that in just a moment. You have to make the request voluntarily. You have to be able to consent to receive medical assistance in dying. And initially, when this was implemented in 2016, your death had to be foreseeable. We'll see how that changed in 2021. Okay, so to have a grievous and irremediable medical condition, this is what the criminal code says, is that a person has this sort of medical condition only if they meet the following criteria. So you have to have a serious and incurable illness, disease, or disability. The person has to be in an advanced state of irreversible decline in capability. That means that the person's never going to get better. That illness, disease, or disability, or that state of decline causes the person to endure physical or psychological suffering that is intolerable to them and that cannot be relieved under conditions that they consider acceptable. Again, the fourth condition that was removed was that the natural death had to be reasonably foreseeable, taking into account all of the other medical circumstances without a prognosis necessarily having been made as to the specific length of time. So your death did have to be reasonably foreseeable, but there wasn't a time placed upon that. So in 2019, there was a Quebec court decision which challenged the foreseeable death requirement. The challenge was that it was unfair to people whose death weren't foreseeable, but they were suffering. And so in 2021, the federal government passed Bill C7 to amend the criminal code to expand MAiD eligibility to individuals whose natural death is not reasonably foreseeable. So this created just a little bit of background here. A lot of concern in the disability community when this legislation was passed in the first place because of that slippery slope argument, recognizing that, you know, this could get bigger than it's intended. And so when the foreseeable death requirement was removed, a lot of advocates argued that you're effectively targeting people with disabilities because those are the people that are left. So in 2021, it was determined that Canadians whose only medical condition is a mental illness. Okay, so let me go back here. Bill C7, when it gave the amendment to remove the foreseeable death requirement, it also stated that they would consider allowing eligibility based on a mental illness only. So you didn't have to have any other medical conditions, but they in the legislation itself or in the amendments, it said that they would wait for 2 years to give the Minister of Justice and the Minister of Health time to initiate an expert review panel in order to make recommendations on protocols, guidance, and safeguards for MAiD for persons suffering from mental illness. That expansion was further delayed by another year, and then the government announced that it would not pursue expansion until after the next election. So we came very close to having mental illness be the sole ground that a person could apply for medical assistance in dying, but the government, I think under public pressure, kind of backtracked a bit and said, no, we're not ready to do this. So if there's questions, feel free to put them in the chat. I can either answer them now or later. The other amendments to Bill C7 was that for people whose death is reasonably foreseeable, they allowed to waive final consent if the person was at risk of losing capacity in the interim. So in other words, if a person knew that they wanted to apply for medical assistance in dying and they knew that their death was foreseeable, but they wanted to live as long as possible up until the time of the process, this legislation allowed for people to give advanced consent to say, at this point in time, I would like to have MAiD happen. And this happened, there were cases where individuals wanted MAiD, but they wanted to live a little bit longer, but they were afraid they were going to lose the capacity to consent. And so there were individuals who actually died earlier than they wanted to because they didn't have the advanced, the ability to waive final consent. So they amended it to allow for people to do this. It also, interestingly, through my research in this area, it became clear that there's not a whole lot of there's regulations in place in the criminal code, but there's not a lot of standards developed across the country on how do these processes work? How do doctors make that assessment, right? That there's a lot of guidelines around the assessment process, but not how doctors make those decisions. And so one of the other things was that it didn't actually have a lot established. The government didn't have a lot established in terms of data collection. So they were only collecting cases where individuals had applied for MAiD and received it, but they didn't collect any data on people who were requesting it but maybe didn't receive it. Also, they didn't collect information on Indigenous identity, disability, or other elements. So when we think about intersectionality, there was no data collection required on the part of the government to look at how different groups of people are affected by this legislation. So as of 2022, this data now has to be collected. So we'll see how that unfolds. So in terms of safeguards, and some folks argue that these safeguards are sound, other folks argue that there's a lot of concern about how this is playing out. So you have to have 2 independent medical assessments when you're applying for MAiD. So 2 different doctors who are independent of each other have to agree that you qualify for medical assistance in dying. So now we have 2 tracks. We have the track where your death is foreseeable, and we have the track where your death is not foreseeable. If your death is not foreseeable, there's extra safeguards in place. One of the medical professionals has to be a specialist in the condition that you have, for example. So that's an extra safeguard for people whose death is not reasonably foreseeable. The person, before they can get MAiD, they have to make a written request, and it has to be signed by an independent witness. They have to know that they can withdraw their request at any time, right up to the point of actually getting MAiD. The person can withdraw. They have to provide final consent or advance consent before receiving, so they have to provide consent before receiving medical assistance in dying. In terms of the 2 medical practitioners, in order for them to be considered independent, they can't knowingly benefit from the patient's death, and one cannot hold a position of authority over the other. And they can't be connected to the other patient in a way, to the other person or the patient in a way that could affect their objectivity. So they must make sure that all patients meet the eligibility criteria, and the second practitioner must also confirm this in writing. Okay, so just recently, the most recent statistics were provided on MAiD deaths in Canada. Just have to excuse me for a moment. I'm trying to move the black bar that's on top of my screen here. So I really wanted to point this out because of the alarming number of people who've received MAiD in Canada. If you look at Nova Scotia, for example, in 2016, we had 24 people receive MAiD. In 2022, there were 274 people who applied for and received MAiD um, in Nova Scotia alone. We see that the numbers are growing quite a bit each year, and this is a concern for a lot of people. If you look at the report that I'm referencing here, the number one reason why people with a foreseeable death request MAiD is cancer. And then if your death is not foreseeable, it's usually neurological conditions. But there's a lot of concern. And at one point in Nova Scotia, I don't have the date offhand, but I remember that the government announced that there would be a hold on the wait list. So you couldn't apply for MAiD because they had so many applications to get through, they couldn't keep up. So there was a one month delay in people applying for MAiD because there was just too many requests being made. There's some stats that aren't collected due to privacy reasons. So you'll see in the explanatory notes that some of the territories don't have complete numbers because of the risk of breaching confidentiality. But if you look at it, there were 10,000 people who received MAiD in Canada in 2021, and in 2022, there were 13,241. So since this legislation was enacted, 44,958 individuals have received medical assistance in dying in Canada. Other jurisdictions, there's only probably about 10 to 15 jurisdictions or countries that have MAiD. Don't have, I don't have the stats on that. I'm still working to collect that with a group of people. We're going to try to do a comparison between Canada and other countries because a lot of people are raising the alarm about the number of people that are receiving MAiD. And I'll talk about some of the issues with that in a moment. Okay. So there's some notable concerns that I want to go through right now. In the report that referenced the number of MAiD deaths in Canada, this report also noted that 53.8% of individuals for whom death was not reasonably foreseeable required disability support services, and that was compared to 36.8% of the overall MAiD recipients. So that's a high number. Over half of the individuals whose death wasn't foreseeable, they required disability supports. I'm going to talk a little bit about media coverage on some troubling stories of people with disabilities who applied for MAiD due to non-medical reasons. And it was really media coverage that was the reason why I became concerned and interested in this topic. I'll just pause here for a personal story. I was doing my PhD. It was around the time the pandemic had just started, so 2020. I was towards the end of my PhD, and I knew that medical assistance in dying had become law. I'm not opposed to MAiD. I think if it's a person's choice to choose that. And I teach about this in my courses too. But what I say to people is I'm not opposed to MAiD. What I am opposed to is the government setting up a system where we don't have adequate social and housing supports for individuals, but then we're making it easier for them to receive medical assistance in dying than to receive the supports that they need. So is it really a choice? That's a question that a lot of human rights advocates are asking at this moment. So in terms of going back to the media coverage, I was, listening to the news one day and I had heard a story of a woman in Toronto who, I lived in Toronto, and at that time the pandemic had just started. So if you needed food, for example, you often had to get it delivered or only one person in your household could go to the store. And the cost of things was also rising. So this woman was on the news to say that so this was the end of 2020. In 2021 was when they removed the foreseeable death requirement. And this individual was saying that Because of the restrictions due to the pandemic, she couldn't get access to home care because of the distance requirements that were in place at the time due to COVID. So she couldn't get access to home care like she needed. And also, the cost of groceries was just going up really high for her because, of all the additional costs with getting groceries at that time or getting food at that time. So she said, when they expand MAiD, I'm going to apply because I can't live like this. She said that it was easier to apply for medical assistance in dying than it was to try to get the support she needed because it just wasn't available. And I remember thinking at that time, how is that even going to be possible? How can people apply for medical assistance in dying for non-medical reasons? Well, in 2022, a joint committee on medical assistance in dying, which was tasked with looking at how MAiD was playing out in this country, raised concerns, particularly from the medical community, that MAiD requests are being made based on non-medical reasons, and I quote, related to poverty, lack of adequate housing, social exclusion, and other social determinants of health, rather than due to their illness. So again, concern from the medical community and others that poverty was interacting with disability and other circumstances to create a situation where people were applying for MAiD. So I'm going to talk just a couple minutes about a project that I'm currently working on. We had a team of people that were collecting stories, news stories of individuals who were affected by MAiD in some way, particularly people with disabilities who are applying for MAiD for non-medical reasons. So again, like I said before, the government hadn't established a whole lot of regulations around data collection, and it's really hard to get access to that data. So we thought another way to figure out how this is actually impacting people is to look at what's being said in the media, who's sharing their stories, and what are they saying. And so this is important for a couple of reasons. One, because it also documents not only people who are applying for non-medical reasons, but also people who didn't go through with the process for whatever reason they might have. And I'm going to give a few examples here. Um, I've given some links in this presentation here on just a couple of stories of people who made or wanted medical assistance in dying. So they made applications or they wanted to make applications for non-medical reasons. So again, there was a woman with chemical sensitivities in Toronto, this first story here, who chose medical assistance in dying because she couldn't get access to housing that could accommodate her chemical sensitivities. And I should have said at the beginning of this presentation that this work is very difficult. I've been going through a number of stories, more than dozen so far, where people are talking about either applying for MAiD or families are talking about people who applied and actually received MAiD for reasons related to their socioeconomic circumstances. And it makes me very angry when I see these stories, and I get very um, passionate about this. But I should have given a warning at the beginning that this is a very, very difficult topic because it affects people in their daily lives. It affects families. And there's just so much that we don't know about what's happening in people's lives. So there was another case of a woman who chose to die with medical assistance because she struggled to get home care. Um, these are just four stories that I've noted here. There's a woman here in Cape Breton who was seeking MAiD because of the complications she had with workers' compensation. So she acquired a disability. She required certain um, food accommodations, I guess you could say. She wanted workers' compensation to accommodate that. They wouldn't because of the lack of resources to get the food that she needed. Her health declined. She still fought with them and then decided that she was going to apply for MAiD because she wasn't having much success. Um, the case is still ongoing, I believe. I don't think she has actually gone through with the process. I should have noted that um, this process, when you apply for MAiD, there's a 90-day waiting period. So if you apply and you're approved, you have to wait 90 days and then you can go through with the procedure. So a lot of advocates have said, and doctors and medical professionals have said that you're making it really easy for people. Some people say that the safeguards of having that 90-day delay will maybe make people rethink whether or not they want the medical assistance in dying. But a lot of people are saying, so in 90 days, you can provide somebody with medical assistance in dying as a healthcare option, but you can't give them what they need to live a quality of life. And so another person was documented to say that he was going to apply for MAiD because he was being evicted and he couldn't find housing. In that case, the man, his story made the media, and some individuals came together and they raised, I think it was $60,000, and he decided not to go through with MAiD. There's a story on him. There's been a lot of news coverage on a lot of these stories, and there's been a few documentaries as well with people sharing their stories. Um, and then we have individuals who um, went to a medical professional and were um, told about MAiD, maybe even encouraged to apply for it, even though that's not what they were there for. So in one case, a man was receiving, uh, I guess, a suggestion that he should apply for MAiD, and upon realizing what was happening, he decided to record the interaction with the hospital staff. Another person in Newfoundland says that the doctor brought up MAiD as an option for her sick daughter. Her daughter had a couple of disabilities, but had suggested that she should encourage her daughter, who was 25, to apply for MAiD, and then said that if she didn't do so, that would be selfish on her part. So, in these cases, a lot of people have come forward to file complaints. There was the case of the Canadian Paralympian who said, she was asking for a ramp for accessibility reasons, and was offered euthanasia or MAiD instead. And so a lot of these stories are featured in Canadian press, but also in the States and in the UK, and other countries are looking at Canada and saying, Why is this happening?" There was another case of an individual, a young man who was applying for MAiD because he had diabetes and complications from an eye surgery. He applied for MAiD. He was approved. His mother um, found out about his application only after it was done, because medical professionals, they're not allowed to share with family if somebody is applying for this process because of confidentiality. But she found out that her son was applying for MAiD and receiving it and had the date set and everything. So that would have meant that the person had two doctors approve the process. And she became alarmed. And so she went to the media and started a campaign to get the doctor to reverse his decision. And he did. And so when I teach about this in my healthcare policy course, I tell students, if a doctor is making a life and death decision, why is it that the doctor is reversing their decision under public pressure? They should be so sure of that decision, medically speaking, in terms of following all the rules and guidelines that, and I'm not saying he shouldn't have changed his mind. What I'm saying is that the safeguards are not enough. So we have a doctor reversing his decision under public pressure, and it's good that he did in this case. But really, we should have a system in place where these assessments are being made by the two professionals, and that there's a good amount of confidence that the person is making this decision for the right reasons. This is really complicated stuff because we're also seeing cases where people are applying for MAiD because they didn't get access to adequate medical care. And we know that healthcare is a huge issue in Nova Scotia and across the country. And if you have a situation where people aren't able to access the healthcare that they need, and then their health declines, but then they're given access to MAiD, that's a real problem, I think. And so I would argue, as do many others, that we should never have had this removal of the foreseeable death requirement until we ensure that we have the social safety net and the healthcare systems that we need to ensure that people are living a good quality of life. So a lot of concern here about how this is playing out. We have policy on paper, but it's looking very different in practice. In practice, it looks like there are a lot of cases where people are given MAiD as an option in healthcare, so the option to end your life. And so this is really troubling because in the cases, so if we go back to the individual who was applying for MAiD because he was going to be homeless, he said, I don't want to die, but I don't have any other choice. And in the research that I'm doing right now, the stories that we've collected, a number of people said, I don't want to die. I just don't have any other options. And so my goal, my priority is to raise as much awareness about this as possible because it's still unfolding. We know that the government is still considering expanding MAiD to allow people to apply based solely on a mental illness. Some of the arguments against that from um, a procedural point of view is that your condition has to be grievous and irremediable. And psychiatrists will argue that there's no way to know if a person's condition will ever get better. You can't guarantee with 100% accuracy whether or not a person's condition will improve over time. And so one of the arguments against expanding MAiD to allow based solely on a mental illness was that you can't predict who's going to get better and who's not. Also, if we think about how all these other systems that are at play are not effectively working for people with medical conditions applying for MAiD, how do we expect, especially with the mental health care systems the way they are in Canada, how do we expect that this will be reasonably applied to people with mental illness? Also, in the expansion process, the government had also considered allowing eligibility to mature minors, meaning that they could be under 18, but that they would have decisional capability. And so that didn't go forward either. Um, so in terms of process, my goal next is to look at, well, what are other countries doing that have MAiD? Because we know that other countries have it, but in many countries, you're not allowed to suggest it. You're not allowed to give advice about it. You're only allowed to provide it if a person, as a last resort. It has to be an absolute last resort. But we're seeing an alarming number of cases where people are given this as a first option. And these are only the stories that were reported in media. And there's no way for us to also track who are the individuals who acquired a medical condition that got to a state of irreversible decline because of their lack of access to quality food, quality housing, quality health care, and then they applied for MAiD, right? So there's that concern as well. There's also been cases where a woman reported that she went to the doctor, was diagnosed with cancer, and she needed treatment for her cancer, but the treatment that she needed wasn't offered in Canada. So she ended up going to another country to get access to the treatment that she needed for her cancer. But when she was being diagnosed, the doctors offered her medical assistance in dying. So she went to the media because, she was offered medical assistance in dying, but she wasn't offered the procedure that she needed. She subsequently then tried to get the government, so she tried to get the government to reimburse her for the expense of going to the United States for the procedure and was declined. And I think they stated that the procedure wasn't recognized as a treatment option in Canada, so they wouldn't cover the cost. So she paid out of pocket, got the surgery that she needed. So again, these unsolicited suggestions of MAiD, a lot of concern from disability advocates, from myself and from others, that we have a situation where coercion could happen, whether it's from a medical professional, it could also be from family members. Again, if we go back to those perceptions that I talked about around being a burden or being pitied, all of these things, right? These can play out in people's minds, and people don't want to be a burden. They don't want to be seen as a burden. And so we want to make sure that people are applying for MAiD because of reasons not related to their health, but actually reasons related to their social circumstances and their economic circumstances. Okay, so again, as I mentioned with COVID, we had a situation where the emergency response benefit was given. Through all of that, advocates started to say, well, shouldn't we not be lifting people with disabilities out of poverty? And so was introduced Bill C-22, which is the Canada Disability Benefit Act. There was a lot of hope around this act when it was first introduced, but immediately we recognized that it's only for working age Canadians, so you have to be between 18 and 65. So already there was concern that for seniors, if we think about complex processes, seniors wouldn't get access to what they to this benefit, only working age Canadians. It turned out that the amount that is available to individuals is about 200, it's $2,400 a year or $200 a month under the Canada Disability Benefit. And it's for those who qualify for the disability tax credit. And I would argue that this credit is one of the most underutilized in the country. And I'll come back to that in just a second when I talk about ways forward here. So I'm just going to check the chat real quick to see if I should be answering questions now.
You're good.
Um,
I'm going
okay,
to, I'll field
thank you.
questions, but we had someone share something just with us, and I wanted to invite them to share it with the whole listeners.
Sh- Sure. Do you want to do that now?
You're okay. I will just say that someone just shared with us, and I'll just read it. Um, that there are different resources provided for MAiD across the country. For example, Nova Scotia has a large team with multiple nurse navigators, nurse practitioners, physicians, psychiatry lead, 2 social workers, etc. However, New Brunswick, for example, has 1 navigator and that's it. Newfoundland has a palliative social worker navigating off the side of her desk. It would be Sorry, I'm trying to read this. It would, sorry. Anyways, I'm trying to read the chat and it's most provinces do not have social workers on MAiD teams, which makes it more difficult to identify social vulnerabilities in case reviews, is what one of our members shared. And I'm going to put in the chat, we've done multiple medical assistance in dying ethics, and we have many of our members who are involved with the Nova Scotia Health Ethics Network on trying to raise these precautions. But I want to just remind people that what Dr. Bernasky is saying is talking about not just the medical assistance in dying piece, but the larger social structures. So right now she's talking about disability tax credit. She's talking about housing, poverty, the larger socioeconomic components. We, and as part of our advocacy day, have been advocating for a shift on that. And I will put some of our YouTube videos that are specifically on that, where we have some of our own members who are advocating to create more precautions and safe pathways for people to access it, because some people do need to,
Mhm.
for lots of reasons. But what Dr. Bernasky is talking about is the concerns around the lack of other resources. So I'll let Dr. Bernasky speak.
Oh, thank you for that, though. That was such a good point. And I would like to recognize here that there's a lot of good people working in these systems, but the system's broken, right? And so what we have is a situation where, a lot of applications go through and they were warranted and people actually wanted MAiD and they received it in the way that they should have. I want to recognize that that's also happening. My concern here is that because of our healthcare system being the way it is, because of our social support networks being the way they are, or sorry, our income support networks being the way they are, people are inevitably pushed towards medical assistance in dying. And I think it is important that there's a number of people that are involved in healthcare to ensure that there's wraparound services for individuals so that they don't feel compelled to apply for medical assistance in dying without first considering all of their other options. Because the law states that you have to give people options. You have to make it clear to them that they can change their mind, and I think it's really important to have as many people involved in that process as possible. I think the other thing that people working with vulnerable people can do is to raise awareness about things like the disability tax credit. It's really hard to get, but when you have it, some argue that it doesn't do enough in terms of it is a tax credit, so you only get back, a certain amount if you pay into a system in a certain way. Um, but it does entitle you to other things like this benefit I'm talking about. So once you have the disability tax credit, you will qualify for the benefit. But it also allows you to access the registered disability savings plan. And a lot of unfortunately there's issues with this too because a lot of people with disabilities they can't save they're living day to day, right? And so there's a lot of situations where individuals don't actually have enough money to live, so how are they going to put money away for the future. However, this is good for families who might have children with disabilities. If they contribute to the system, depending on a number of formulas, the government will match it up to like $1 for three, up to a certain amount. So it's actually quite an aggressive savings plan for people with disabilities that they can access later in life. And I think, but you first have to have the disability tax credit. And I've done research on this in the past where people have said, it's really hard to get access to that credit unless your disability is very obvious. Even if you have a obvious permanent disability, sometimes you have to requalify um, after so many years or whatever. But it's really important to make people aware of this credit and aware of other kinds of services that are available, because the goal for me is to raise the profile of people with disabilities and vulnerable people, and also to ensure that people have the resources that they need.
Thank you. And I'm just going to say for those people who are not part of our awesome chat conversation, because you're watching this YouTube video later, the more that we understand and understand how to support those with disabilities and all of these resources and can advocate, then the more we can ensure that folks have access to options so that when they do make a choice, that it's an informed choice with actual choices, right?
Mhm.
There's no housing option,
Yeah.
which is outside of the scope of any social worker, except that's why we have our, advocacy toolkit with the Legal Information Society of Nova Scotia. Then if that's your only option, is it really a choice? Is what Dr. Tammy Bernasky is saying.
Thank you. Yeah. I think social workers are in a very good position to help people navigate these systems. They are complex though, right? And so it can be hard for anybody navigating, if you have one support, you don't have access to another, it might jeopardize one thing or another. It can be really stressful for people, right? So there's a clear gap in support for people with disabilities who are living in poverty. It can create a lot of stress and tension in a person's life. And there's a lot of concern raised about the implementation of MAiD without having first established those supports to enable people with disabilities to live in dignity. And that's not to say that there's not a lot of, professionals and other people in society and medical professionals and whatnot who are helping people live a dignified life, but it's to raise the concerns about the people who don't get access to those services. So more awareness needs to be raised about the number of people who are applying for MAiD for non-medical reasons. It's been documented in committee reports, it's been documented in the media, despite those clear guidelines that don't allow this. And so I guess my objective today is just to raise this profile a little bit. And I'd love to thank you for your time today. So thank you very much.
Thank you very much. This has been such an important part of our learning, and obviously it's complicated and it's hard. I want to remind people that if you want to get a copy of Dr. Bernasky's presentation, you can email me or the college, and we will have that for you. This is part of a large series of ethics and educational resources that we've done. We have many of them on our YouTube channel around concerns around the medical assistance in dying expansion for mental health. We had one with not only some of our colleagues who are doing beautiful work with the Nova Scotia Health Ethics Network, and we also had the executive director of the Canadian Mental Health Association talking about it. But we also recognize the larger structural pieces that are causing people to feel like it's easier to get an appointment to die than it is to get an appointment to live. And the access for disability, like a ramp. We north of the colonial border do not have the kind of disability access that south of the colonial border has. But then, Dr. Bernasky, can you say a little more about that situation with a person who had cancer, who could not get medical treatment in Canada for the cancer and had to go to the States to get it, and then um, and that person, could you share more about that?
Yeah, so I can only share what I've seen in the media because I don't know the person individually. And so basically, they were diagnosed with cancer, and it was quite stressful for them. And the doctor was going through all of the options, and MAiD was one of those options. But the person, she didn't want MAiD, and she wanted to look for ways to access services. So she actually looked at a couple of different countries, and she ended up going to one of the states in the United States to get the medical care that she needed. Um, Again, like I said, when she got the medical care, she thought, okay, well, I got the medical care elsewhere. Perhaps, my government, my provincial government will then reimburse me for that. I think she ended up paying about $20,000 out of pocket, but that's about as much as I know, is as much as she shared in the media. But certainly there's concerns there about people going to other countries to get access to medical care. We've seen this in other forms as well, not specifically related to medical assistance in dying, but people just having, because there's so many issues in our healthcare system, feeling like they need to resort to going to other countries. So in Canada, we have um, public health care. We're supposed to get it, when we need it. We're supposed to get medically necessary services, right? But what's considered medically necessary might be up for interpretation sometimes, right? So it might feel medically necessary to the individual who is progressively getting worse in a situation, but it might not be considered medically necessary when you think about all the other cases that are in play, and when medical professionals have to prioritize situations. So I'm still in the midst of going through all of the stories that we have collected so far, but there's been concern that people are going to other countries to access services, and then are also concerned that they were offered MAiD in the first place. It should never be a situation where somebody's given it as a option. Even with the veteran that I mentioned, there were a number of cases where a caseworker at Veteran Affairs offered MAiD to several, not several, maybe five, I think four or five. It's hard to know because they're listed as anonymous, so I can't really tell how many there are in total, but at least four, perhaps five, were told that they could access medical assistance in dying when they were calling for things like a brain injury or post-traumatic stress disorder. And so that actually made its way not only up in the media, but also in government as well. And there was a hearing on this case as well. Some people say it was the individual worker at Veteran Affairs. I'm not sure because I don't have all the information, but concern again that people were trying to access services for PTSD and were offered MAiD. Yeah.
And I want to just remind people we have medical assistance and dying guidelines that note that social workers are not able to offer that, like that's not something within our scope of practice. We can support people in the way they navigate through the system, but so just make sure that you check our medical assistance and dying guidelines that is on our website. And you will also see when you go to the YouTube channels people who had disabilities who had felt like they only had that option here because there wasn't the medical treatment available, but then they moved to Alberta, for example, where they were able to access the kind of living supports that and treatment supports that allowed them to recover. So that is just another thing to know. Uh, Dr. Bernasky, we understand that this whole field is brand new. Like we're figuring it out as we go. I mean, this is uncharted territory for the country as a whole, for all of us as we navigate through this complicated thing. And you are doing important research that is helping us begin to understand that further. And we are grateful to you for sharing so beautifully. Again, this is your second Lunch and Learn with us. You did one with us last month as well. And we are so grateful. And one of your students is in the audience because one of your students is also a social worker and is
Oh,
talking about
great.
how amazing you are. So,
I remember her.
no, we are grateful to you for sharing and for your advocacy, especially considering how close to home this hits for you. This is really difficult. But we as social workers are advocating for a transformation of our current medical system to understand the role of the psychosocial, structural, economic, and spiritual components of care that are not yet currently integrated in an optimal way in our healthcare system. everything is imperfect in this world. This is not about pointing fingers. This is about how can we work collectively to transform our current systems into ones that can better support everyone so that there are more choices. And we are grateful especially to our members that are working in the medical assistance and dying um, areas in Nova Scotia with the Nova Scotia Health Ethics Network to try to put as many precautions and processes in place to support and flag when there are those situations. But we recognize that we need more research, we need more understanding, we need more first voices to be informing how government creates policies that then all of us social workers implement through our practice. It's a mutual relationship and we're just beginning. But thank you for everything that you are doing and for sharing some of that with us. And again, if you want a copy of Dr. Bernasky's presentation, you can email me or I will also, since this is actually my last day, at the college. And I felt like this was a really important way to kind of end my last day because we are talking about psychosocial and structural determinants of health. That's part of the repositioning report in 2021 that Nova Scotia College of Social Workers has been advocating for an expansion of the ways in which we can be well as we work to decolonize ourselves, our practice, and this planet as a whole. Dr. Bernasky, we're so grateful to you for sharing, to all of our colleagues that are doing amazing work. Thank you for what you are doing and for how you are trying to, in your own respective ways, advocate for improved resources, whether it's poverty, whether it's housing, whether it's disability access, whether it's a ramp, whatever that is, what you are doing matters. And don't forget our advocacy toolkit. You can contact your MLA and share your concerns as a private citizen. And hopefully this can help raise more awareness around how can we improve our processes so that those people who want to live have options that are accessible to them. Deeply grateful to everyone. Dr. Bernasky, thank you so much for sharing of your wisdom, and we hope to continue to learn from you.
Thank you too. Take care.